Imagine a pain so sharp that it literally stops you from taking a breath.
Yeah, yeah.
You're fine 1 minute, maybe you just had a rich dinner, and an hour later you're doubled over. You're convinced you're having a heart attack or something just ruptured inside you.
It's terrifying when it happens.
It really is. And it's deceptive because the organ responsible is so small. It's just this little pear-shaped sac tucked away right under your liver.
Yeah, it's always the quiet ones you have to watch out for.
Absolutely. So today we are doing a deep dive into the gallbladder. Specifically, we're looking at a condition called cholecystitis.
Which is quite a mouthful.
It is. And before anyone tunes out thinking this is just some medical jargon for a tummy ache, we really need to set the mission for today. We're looking at why this happens.
The mechanics of it.
Exactly. Because this isn't just a stomach bug. This is a mechanical failure that turns into a full-blown chemical disaster. We're talking about plumbing, pressure, and how something the size of a pebble can entirely shut down your digestive system.
It is a biological disaster movie, really.
And we have some great source material for this deep dive. We're pulling from medical literature, covering the pathophysiology, the diagnostic criteria, and the current surgical standards.
Right, the real clinical data. And what's helpful is that the name itself kind of gives away the plot, if you happen to speak a little ancient Greek, that is.
Oh, I love that we're starting with the etymology. It kind of grounds the complexity for us.
It does. So if you break it down, chol means bile. Cyst is a bladder or a sac. And itis.
Inflammation.
Exactly, inflammation. So put it all together and you literally have inflammation of the bile sac.
Inflammation of the gallbladder.
Right. But as we dig into the mechanisms today, I think we'll see that inflammation is, well, it's a massive understatement for what's actually happening to the tissue in there.
Yeah, because we aren't just going to list symptoms for you today. We want to understand the why. Like, why does a problem in your abdomen make your shoulder hurt?
That's a weird one.
Or why is rapid weight loss a trigger? And why are the silent types of this condition actually the most dangerous?
That distinction right there between the noisy, painful type and the silent, deadly type, that's probably the most important thing to grasp today.
So let's start with the noisy one, which accounts for the vast majority of cases. We're talking about acute calculus cholecystitis.
Right.
Calculus sounds like high school math, but in medicine, it actually means pebbles or stones, right?
Exactly. This is the 90% scenario.
Right.
So you have the gallbladder, which essentially acts as a holding tank. It's a storage tank for bile that's produced by the liver.
Okay.
And when you eat, especially when you eat fats, the gallbladder squeezes. It pushes that stored bile through a little tube called the cystic duct and dumps it into your intestine to help break down the food.
So it's basically a little soap dispenser for your digestion.
That's a perfect way to think about it. But the problem arises when one of those stones, a gallstone, decides to take a trip.
And gets stuck.
Right. It gets wedged right in the exit door, the cystic duct.
And this is where the mechanics get really interesting. Because it's not just that the bile can't get out. The gallbladder is made of muscle, right?
Yeah.
It doesn't know the door is jammed.
It has no idea. So it just keeps contracting. It's trying to push against this physical blockage.
So you have a solid blockage, but you also have the liver still producing bile, and the gallbladder desperately trying to squeeze. It's a pressure cooker.
It's exactly like kinking a garden hose, but leaving the faucet running on full blast. The pressure inside that little organ skyrockets.
Wow.
The wall of the gallbladder becomes completely distended. It gets red, it gets tense, it swells up. But here is the critical insight from the literature that I think people often miss.
What's that?
Bile isn't just water. As you said, it's a soap. It's a detergent.
It's meant to break down fats.
Precisely. It is highly caustic. So when you take that concentrated detergent and you trap it under extremely high pressure, it starts to chemically burn the lining of the gallbladder itself.
It's essentially digesting itself.
It damages the mucosa, yes. So now you have intense physical pressure compounded by chemical irritation.
And as that swelling pushes outward, because the pressure has to go somewhere, it starts to squeeze the actual blood vessels that feed the organ.
That is the tipping point. In the medical literature, we call it ischemia.
Ischemia.
Right. Think of it like a balloon that you've blown up so tight that the rubber turns white.
Oh, I hate that visual, but it makes so much sense.
That whiteness is the blood literally being squeezed out of the tissue. And without blood flow, you don't get oxygen. Without oxygen, the cells start to die.
That perfectly explains why the pain is so relentless. It's not just a muscle cramp. You're feeling your tissue starving.
Yes.
And I assume once the tissue starts dying, the environment stops being sterile. because the gut is right there.
You're exactly right. That's the final stage of this whole disaster cascade. Under normal circumstances, bile is sterile.
Okay.
But with stasis, meaning nothing is moving in or out, and with the tissue dying, bacteria seize the opportunity. They migrate up.
From the intestine.
Right. You get colonization, usually things like E. coli, Klebsiella, just the usual suspects from the gut flora.
So let me get this straight.
Right.
You have a blocked, chemically burned, oxygen-starved, infected organ.
Yes. That is acute calculus cholecystitis.
That is a terrifying combination. Now, that covers the roughly 90% of cases caused by actual stones. But we mentioned a silent type earlier, the 10% where there is no stone at all.
Right. A calculus cholecystitis, literally meaning without stone.
This one honestly scared me when I was reading through the sources. How do you get all that severe inflammation and tissue damage if there's no rock blocking the exit?
It's a completely different clinical picture. This is a condition of the critically ill. You don't just get this walking around on a Tuesday afternoon.
So who gets it?
This happens to patients who are typically already in the ICU, people with severe burns, major trauma, widespread vasculitis, or people recovering from massive surgeries.
So they are already fighting for their lives.
Exactly. And because of that, it seems like a use it or lose it situation for the gallbladder.
How so?
If you are in a coma or you're on a ventilator, you aren't eating by mouth. And if you aren't eating fats, your gallbladder never gets the hormonal signal to contract.
So it just sits there.
The bile just sits there. It becomes incredibly thick. It turns into this dense sludge.
And since these ICU patients often have very low blood pressure anyway, or they're in shock, the blood flow to their organs is already compromised.
You nailed it. It's a perfect storm. You have bile stasis from the sludge combined with systemic ischemia from their overall critical condition.
The tissue just gives up.
The tissue starts to necrose, to die without a stone ever being involved. And here is why it's so deadly.
Because they can't tell you they're in pain.
Exactly. They are sedated, unconscious, or intubated. They can't say, my stomach is killing me. So the morbidity and mortality rates for the calculus type are significantly higher simply because it's caught so late.
That is a very sobering reality. But for those of you listening who aren't currently in an ICU, you're mostly going to be worried about the stones.
The 90%.
Right. And I think most people have this vague idea that eating a really greasy meal causes this. But let's look at the actual risk profile from the literature. Who is the prime target for a gallstone attack?
There's a demographic breakdown that's very well established. We look at female sex, age specifically peaking between 50 and 69, and obesity.
So middle-aged women are at a significantly higher risk.
Yes. And a large part of that has to do with estrogen, which actually increases the amount of cholesterol secreted into the bile. Pregnancy and birth control pills can also elevate that risk for the same hormonal reason.
And obesity makes sense too, right? More overall cholesterol to potentially form stones.
That's the basic mechanism, yes.
But the risk factor that always throws people, the really counterintuitive one, is rapid weight loss.
It feels incredibly unfair, doesn't it? You go on a strict diet, you try to get healthy, and your gallbladder completely punishes you for it.
It's a chemistry problem, though, isn't it?
Yeah. It is entirely a chemistry problem. When you lose weight very quickly, say through a crash diet or after bariatric surgery, you are metabolizing your fat stores at a highly accelerated rate.
You're burning the fat.
Right. And that fat is stored energy, but it is also packed with cholesterol. So as you burn it, your liver has to process all that released cholesterol and dump it somewhere.
It dumps it into the bile.
Exactly. You end up flooding the system. You are supersaturating the solvent.
Meaning the bile just can't dissolve it all.
Right. The bile becomes so overwhelmingly rich in cholesterol that it physically cannot keep it all in a liquid state. It starts to crystallize.
And those crystals clump together to form the stones.
Precisely.
Now, speaking of demographics and risk, there was one statistic in the sources that really stood out to me. It's regarding American Indians.
Oh, the prevalence rate. It's a staggering number. Nearly 48% of American Indians have gallstones.
Almost half the population. That's incredible.
It's a powerful reminder that while lifestyle and diet are huge factors, there is a deep genetic architecture at play here that we just cannot ignore. Some populations simply have a strong genetic predisposition to secreting higher levels of cholesterol into their bile.
So let's say you fit the profile. Or maybe you don't fit it at all, but you're having bad stomach pain. How do we play detective here? Because heartburn is incredibly common. Indigestion is common. How does someone distinguish, I ate too much spicy food, from my gallbladder is currently dying?
The key differentiator clinically is the persistence and the nature of the pain. We usually see a warning shot first, which is called biliary colic.
What does that feel like?
You eat a heavy, fatty burger, you get this intense cramping pain in the upper right side of your belly. But it goes away after an hour or two.
So that's the stone blocking the duct temporarily, but then kind of falling back into the sac once the squeezing stops.
Exactly. It's intermittent.
Yeah.
But with true acute cholecystitis, the stone gets stuck and it stays stuck. The pain does not stop.
It becomes constant.
Constant, severe, and very specifically located in the right upper quadrant, right under your rib cage on the right side.
But then there's the weird symptom, the referred pain.
Oh, the shoulder pain.
This blows my mind every time I read about it. You have a localized abdominal issue, but your right shoulder blade, specifically right below the right scapula, starts throbbing. The literature calls this Boas's sign.
It is so bizarre, but it's basically a glitch in our internal wiring. It comes down to human embryology.
Oh, so.
The nerve pathways that supply the gallbladder share a sort of neural superhighway with the phrenic nerve. And the phrenic nerve relates to the diaphragm and runs right up to the shoulder area.
The signals get crossed.
Exactly. The brain receives this massive distress signal from the gallbladder, but the mapping gets confused. The brain interprets the pain as originating up in the shoulder.
So if you have a terrible constant stomach ache and your right shoulder hurts for no reason, you need to get to a doctor.
Absolutely.
Now, speaking of going to the doctor, there's a specific physical test they do in the exam room that sounds almost theatrical. It's called the Murphy sign.
It's a classic. It's one of the few physical exam maneuvers we have that is almost as reliable as an imaging test.
Paint the picture for us. You're the patient in the ER. What is the doctor doing?
The doctor will put their hand firmly on your right upper belly, tucking their fingers just under the edge of your rib cage.
Okay, pushing in.
Right. And then they ask you to take a really deep, big breath in.
And as I inhale,
As you inhale, your diaphragm naturally moves down to expand your lungs. But as it moves down, it pushes your liver and your gallbladder down with it.
right into the doctor's hand.
Exactly. It essentially shoves that inflamed, angry gallbladder directly into the doctor's fingers. And if that organ is inflamed, that physical contact causes a blinding spike of pain.
And it's the patient's reaction that is the actual sign, right?
Yes, the reaction is completely involuntary. You gasp and you literally stop breathing mid-inhale.
Because it hurts too much to keep filling your lungs.
In medicine, we call it inspiratory arrest. You physically cannot finish taking the breath because the pain simply cuts it off. That sharp gasp is a positive Murphy sign.
That is so visceral. But obviously we have better diagnostic tech now than just poking people in the ribs until they gasp. Ultrasound is the gold standard, correct?
It is the gold standard. It's fast, it's relatively cheap, and there's no radiation. The tech is looking specifically for a thickened gallbladder wall. Anything over 3 millimeters is suspicious, and they're looking for fluid pooling around the organ plus the visual confirmation of stones.
And what if the ultrasound is fuzzy? Because sometimes the patient has a lot of bowel gas blocking the view, or maybe they have a larger body habitus.
If the ultrasound is inconclusive, we go to the backup, which is the HIDA scan. And this is just really cool physiology in action.
How does it work?
We inject a safe radioactive tracer into the patient's bloodstream. The liver naturally pulls that tracer out of the blood and secretes it directly into the bile. Then we put the patient under a special camera, and we just watch. You should see the gallbladder literally light up on the screen as it fills with this glowing bile.
But if the door is blocked,
If the tracer flows everywhere else down into the intestine, into the liver, but the gallbladder itself stays completely dark on the screen.
means the tracer can't get in because the stone is blocking the cystic duct.
Exactly. It is a definitive functional diagnosis. We also run blood work, of course. We look for a high white blood cell count, usually elevated around 12 to 15,000, and a high C-reactive protein, which just confirms severe systemic inflammation.
Okay, so we've played detective, we've diagnosed it. Now I want to get into the horror story section of the literature, the complications.
It gets grim.
Because I really feel like some people might think, you know what, it's just a gallbladder. I can tough this out at home.
You really can't, and you shouldn't try.
We talked earlier about ischemia, the lack of blood flow and the tissue death. If you ignore that, that leads to full-blown gangrene.
Which is exactly what it sounds like. It's dead, rotting tissue sitting inside your abdomen, and dead tissue loses its structural integrity. It becomes very weak.
So it can tear, it can rupture.
It can completely burst.
And a rupture means all that infected caustic detergent we talked about earlier just spills freely into the abdominal cavity.
Which causes peritonitis. That is a massive, life-threatening surgical emergency. The mortality rate for a massive rupture hits 30% in some clinical studies.
30%? That's huge.
It is. But honestly, there is a complication that I find even more fascinating and kind of horrifying than a straightforward rupture. It's what we sometimes call the great escape attempt by the gallstone.
Oh, right, the fistula.
Yes. This is truly bizarre biology. Imagine the gallbladder is so severely inflamed, so swollen and sticky, that it actually adheres to the loop of the small intestine that's resting right next to it.
The duodenum.
Right. It fuses with the intestine.
Like they're literally glued together by the inflammation.
Exactly. And then over days or weeks, the constant mechanical pressure of that trapped stone literally erodes through the wall of the gallbladder.
And since it's fused to the intestine.
It erodes right through the wall of the intestine, too. It creates a secret tunnel, a fistula.
So the stone entirely bypasses the little black duct and just falls directly into the gut.
It sounds like a clever solution, doesn't it? The stone is finally out of the gallbladder.
But I'm guessing it's not a good thing.
No, because these stones are often huge. We're talking the size of a large walnut, sometimes even a golf ball.
Wow.
So this massive rock travels down the small intestine until it hits a very narrow natural checkpoint called the ileocecal valve. That's the valve that separates the small intestine from the large intestine.
And a golf ball is definitely too big to fit through that valve.
It plugs the valve completely. Now you have a total bowel obstruction caused by a gallstone. In the literature, it's called gallstone ileus. So you just went from having a localized gallbladder problem to having a completely blocked intestine. You're vomiting, you can't pass anything, and now you need major emergency bowel surgery.
That is just wild. A rock from one tiny organ creates a secret tunnel to travel down and completely shut down a totally different bodily system.
It really highlights how adaptable the human body is, but in the absolute worst possible way. Oh, and I should also mention empyema as a complication.
What's that?
It's when the entire gallbladder just fills up with pure pus. It essentially becomes an internal abscess.
Okay, that's enough horror. Let's avoid the secret tunnels and the pus and the gangrene.
Yeah.
Let's talk about the fix. Because the clinical consensus seems to be quite simple. Get it out.
Surgery is the definitive standard of care fix. We perform a laparoscopic cholecystectomy.
Which is the modern keyhole surgery.
Yep. Right. 4 small incisions on the abdomen. We use cameras, we use little robotic arms or specialized instruments. The surgeon goes in, clips the cystic duct shut, clips the blood supply, carefully peels the gallbladder right off the bed of the liver.
Puts it in a little tiny bag?
Yep, puts it in a specimen bag and literally pulls it out through your belly button.
The marvels of modern medicine. But there's a strict timing element to this surgery in the guidelines, too. You mentioned the 7-day rule.
The clinical data is very compelling on this. If you are diagnosed with acute cholecystitis, you want to operate early. Ideally, you want that surgery within 7 days of your symptoms starting.
But why the rush? If someone's in a lot of pain and inflamed, why not wait 6 weeks? Let the inflammation cool down, give them some antibiotics first.
It's a mechanical issue. The intense acute inflammation makes the tissue friable.
Friable meaning it tears easily?
Exactly. It crumbles, it bleeds easily. It does make the surgery technically harder. But waiting is actually worse because as the acute inflammation settles, heavy scarring sets in. Things fuse together permanently.
And you risk all those awful complications we just went through if you leave a blocked organ inside for 6 weeks.
Right. Plus, statistically speaking, the literature shows early surgery leads to much shorter hospital stays and way fewer return visits to the ER.
Now, what if the patient is just too sick for surgery? Maybe they're that ICU patient with the acalculous type we talked about. Their blood pressure is tanking, they can't survive general anesthesia.
In those extreme cases, we use a bridge therapy. We perform what's called a percutaneous cholecystostomy.
So drain through the skin.
Exactly. Guided by ultrasound, we stick a needle through the skin of the abdomen, right into the gallbladder, and we leave a drainage tube in place.
It's literally like opening a release valve on that pressure cooker.
That's exactly what it is. It drains all the pus, it drains the infected toxic bile, it relieves the pressure instantly. Now, it doesn't remove the stones.
But it stops the organ from rupturing.
Right. It resolves the sepsis. It buys us critical time for the patient to heal and get strong enough to hopefully undergo the actual removal surgery weeks later.
Now, before we wrap up, I have to ask you about this, because you see this online constantly, especially on social media. The gallbladder flush.
Oh, boy.
The special teas, the homeopathic remedies. People ask, why can't I just drink a specific mixture of olive oil and lemon juice to flush the stones out and avoid surgery?
I get asked this constantly in practice, and I always tell people to think about the literal physics of what we just described today.
The plumbing.
Yes. You have a hard stone, a solid rock wedged incredibly tightly into a tiny physical tube, or you have a blockage that's actively causing the organ tissue to rot. Drinking a cup of special tea or a glass of olive oil is a chemical input.
Right.
A mild chemical input cannot possibly solve a hard mechanical blockage.
You can't just chemically dissolve a golf ball-sized rock in a few hours when the pipe is physically plugged.
Exactly. And the real danger here is time. While you are waiting at home for your lemon juice and olive oil to magically work, the ischemia is actively progressing. The blood flow is stopped, the gangrene is setting in, the risk of a fatal rupture is rising by the hour.
So it's not just that it doesn't work. It's actively harmful because it delays the real treatment.
Relying on homeopathy for acute cholecystitis is incredibly dangerous because it delays the mechanical solution, which is surgery, that is absolutely required to save the organ from bursting.
That makes perfect sense. Physics always wins in the end.
Physics always wins.
So we've really tracked the journey of this deceptive little pear-shaped organ today. It starts out quiet. It just helps you digest a few too many fries.
Doing its job.
Right. But then a stone forms. Maybe it's your genetics. Maybe it's because you crash dieted for a wedding. That stone gets stuck. The internal pressure builds. The chemistry turns incredibly caustic. And if you try to tough it out and ignore that weird shoulder pain or the gasping breath, you're looking at a massive systemic crisis.
That sums up the literature perfectly. It really is a harsh reminder that we aren't just a collection of completely separate parts.
And that's exactly the thought I want to leave everyone with as we close out this deep dive. We tend to think of our organs in these neat little silos. Like I have my stomach, I have my heart, I have my shoulder. But the body is this deeply, deeply interconnected web.
Everything touches everything else.
Right. You make a choice to lose weight very rapidly, and that shifts the subtle chemistry of your liver. That chemistry change builds a literal stone. And that stone creates a secret tunnel to your intestines and shuts down your bowels. Or it signals severe distress through a nerve pathway that ends up making your shoulder throb.
It is an ecosystem. You pull a tiny thread in one place and a knot tightens somewhere, completely unexpected.
So please, listen to the signals your body is sending. If you are gasping for air when someone touches your ribs, do not drink olive oil and lemon juice. Go straight to the hospital.
Very solid advice.
That's it for our deep dive today. Thank you for exploring the sources with us. Stay curious, stay healthy, and we will catch you on the next one.